You don't do it exactly at the limit with the mucosa, but slightly in the keratinized tissue. Then you elevate the flap with a split thickness dissection. You do it the thinnest you can, even if at the end the flap is so thin that it can tire, it doesn't matter, because you want to keep the maximum soft tissue thickness on your ridge. And then, when you go apical, you can be close to the bone. Then you suture the flap. You use a T-mattress. It's a specific suture to place the flap round from the mucosa. You start like a vertical mattress and you finish like a horizontal mattress in the peristeum. It's a vertical and horizontal mattress combination. And you have to do a lot. If you don't do enough sutures, the flap will go down and you risk a bridging. Then I chose to take your labial strip, and I was lucky because she had some keratinized tissue, labial keratinized tissue enough, wide enough at the mandible. The strip harvesting is fairly thorough. The risk is to cut the strip. That wouldn't be a disaster, but then it's time consuming to reconnect two ends perfectly. So the strip is sutured immediately after its retrieval. At the apical end of the residual bed, with a loop or classical suture, and then with cross suturing. So you do your cross suturing tight enough to make it stable, but not too tight, because otherwise you will have a scar on your strip. I have some cases with scars. And you suture the end on the keratinized tissue. So now it's time for the collagen matrix. So you cut it step by step until you get the good shape. So it's the same collagen matrix, but I split it. So the matrix should not bridge over the strips. That's the reason why we place it 2-3 millimeters from the apically positioned flap. And then we suture the matrix to the recipient bed with a continuous mesh suture. So it's much easier if you keep it dry, much easier to manipulate. this is a 2-week healing. Then we check, we have a shrinkage, around 50% shrinkage. We check soft tissue thickness, and then we do a provisional bridge. We place it with a compression, and this is after the healing, but it's still the provisional bridge. So these are my treatment strategies. We use vocal horizontal defects. We treat the vocal horizontal defects with association. A limited vertical augmentation can be achieved with association in favorable cases. But you need a form stable non-resorbable membrane for vertical augmentation of more than 3 millimeters, for the lingual and palatal augmentations, and for the anterior knife regions. I will now talk a little bit of the complications. So we have 4 keys to reduce the failure rate. First is the patient selection, about the smoking, about the health, and about the compliance. The compliance is a very big point, because we are with our patient for at least one year, potentially 1 year and a half, potentially 2 years for vertical defects. The patient needs to accept to be prepared, to be very well prepared. If you have a prior disease, if you have anything, he needs to have good it that he accepts to be perfectly clean. And you need to do a perfect post-operative care.